So when I was deciding what to talk about today, Jason Puckett always sends me a list of what we've talked about before, and I was surprised to see that we hadn't talked about fatty liver disease. So I've talked about alcoholic liver disease, we've talked about the gut flora, Matt Caves talked about environmental liver disease, but this is actually the thing that I see in clinic every day and where I get tons of questions. And so I thought we'd talk about fatty liver disease. And I'm not going to do any historical stuff like Jesse does at the beginning, but there's going to be a little history during the talk. So on disclosures, the really important thing is that everything that I talk about is off-label or unapproved, and that's unfortunate. And as you see, I used to have no disclosures, but now that all my NIH stuff's done, I'm interacting with drug companies more. And that's very important if you're trying to develop new drugs. So our objectives in the next 45 minutes or so are to go from the obesity NAFLD epidemic all the way through to hopefully some treatment options at the end. And as tradition with Grand Rounds, we'll start off with a patient. And this is somebody that I actually saw fairly recently. A couple people in the audience, Laura Samard, Dr. Marsano, Matt Cave, I think have all taken care of this patient when he was in the hospital. So a 70-year-old physician, increased BMI, metabolic syndrome, turned out to be a neighbor of mine. Came in to see me in clinic because his primary care physician was concerned that his liver enzymes had been elevated for about 10 years or so, and he was concerned about that and that his albumin had dropped down a little bit. And of importance here, this AST-ALT ratio is something everybody needs to remember. So in NASH, the ALT is almost always higher than the AST unless you've gone on to cirrhosis. And on the other hand, the AST is usually higher in alcoholic liver disease. Well, this guy, and I believed him, wasn't an alcoholic, and so I was concerned he might have gone on to cirrhosis. On physical examination, he had a couple spiders, and so that made me even think more in that direction. So I scheduled him for some blood work, which we got back right away. Our workup was negative, and he was scheduled for a ultrasound and an EGD. Unfortunately, I saw him on a Thursday. That weekend, he had a massive upper GI bleed, and I'd given him my home phone number, but I was out of town. So he went to a local hospital, not named Jewish, and that's a problem if you have a liver problem. So he ended up having poor perfusion to his liver, shock liver. We ultimately got him transferred to Jewish. He had an emergency TIPS, and he had encephalopathy for a long period of time. And we were concerned whether he had done really irreparable damage to his brain. So if we fast forward a little bit, what's happening now? Well, when I went home a couple nights ago, there was a food basket on our porch that they had sent, so they seemed to be happy. He's playing bridge now and winning again, so his mental function's good. We're trying to get him to lose a little weight and exercise. And what am I treating him with? So he's on pentoxifylline and a probiotic for his liver, Xifaxan for his encephalopathy, and he's getting regular HCC surveillance. So concerning the obesity NAFLD epidemic, I pulled this slide out. This is a slide I used to use about 10 years ago. And so this is the history part. So actually, back in the late 90s and early 2000s, all the nutrition groups got together and met at one time together. We've never ever done that before or since. But we did it because we wanted to get the press involved in understanding the importance of obesity. the American public didn't get it then. And we were interested in highlighting also the importance of NAFLD. So 1 out of every 3 Americans has fatty liver disease. And no matter what your practice here, whether you're a cardiologist or an endocrinologist, a rheumatologist, obesity affects all of your practices. I just happen to do liver disease, and that's what we're talking about today. So, people with NAFLD coming to my clinic usually come in because somebody said, hey, your ALT is 50, so it's a little bit up, but I'm worried about that, and you're overweight. Most of the patients are asymptomatic. If we did a liver biopsy, it would just look like alcoholic liver disease. And so then this goes back to history. So I can remember actually a couple patients vividly at the University of Kentucky, little old women that I did liver biopsies on, showed classic alcoholic hepatitis, and they swore that they weren't drinkers. And finally, I abused them enough so they admitted they drank wine at Christmas time. And so I just assumed that they were lying to me about their alcohol intake. And indeed, NASH wasn't described until 1980 when Ludwig at the Mayo Clinic had an article on this, and it really wasn't appreciated until almost 2 decades later. The histology makes a difference on your prognosis. So this looks terrible when you look at it under a microscope. It's all fat. And back when I was at UK and even earlier at Minnesota, I loved to show people livers that looked like this under the microscope. I had a double-headed microscope because it scared the heck out of them. So that looks very impressive. But the thing that's disturbing is this ballooning here. So this is just NAFLD, or steatosis. The ballooning and the little fibrosis here moves you into a whole new level as far as poor prognosis is concerned. So again, if you look at what is the big liver disease that we're facing, it's fatty liver. Again, 25%. NASH. Here's hepatitis C here, here's alcohol. So, we've spent tons of money on the hepatitis C epidemic, and it's just a fraction of the NAFLD epidemic. So now I've spent all this time talking to you about obesity, and I want to tell you that that's only part of the story. So this is a global epidemic. So Zobar Younasi did this study published in Hepatology where he looked at NAFLD and NASH across the world. And if you look at prevalence, again, the overall prevalence across the world is 25%. Here's North America, almost to 25%. Here's the Middle East ahead of us, South America ahead of us, Asia ahead of us. So I used to go to conferences, liver meetings, and I'd be talking about obese people in Kentucky and showing these funny pictures. And the investigators would come up to me afterwards and say, we see tons of NAFLD in India, and these guys don't look like this at all. And so it was true. So they do have a little visceral adiposity, but they aren't markedly overweight like a lot of our patients are. And this just shows risk factors, again, across the world. Pretty similar. So a lot of them have diabetes, a lot of them have hyperlipidemia, hypertriglyceridemia, the metabolic syndrome, and hypertension. So the metabolic syndrome's a major risk factor. Now, if you get an ultrasound or you have fatty liver, what would your differential diagnosis be? Well, obviously, drinking is a big one. And sometimes people tend not to tell us the truth about how much they drink. So you need to press people on that. And so healthy drinking, and there is such a thing as healthy drinking, is 1 drink or less for women, 2 drinks or less for men a day. Hepatitis C genotype 3 gives you fatty liver. Some medications do, so we always think about amiodarone, tamoxifen, steroids. So this is macrovesicular fat, what you saw in those liver biopsies. There's small droplet fat called microvesicular fat, and that's usually Rye syndrome. Actually, a lot of medications do it. We see it a lot with the antiretroviral agents. Fatty liver pregnancy and HELP syndrome can do it. For the GI fellows or the endocrine fellows, the board question that you may have is this. So, lysosomal acid lipase deficiency. So this is a cholesterol ester storage disease. And so it's a defect in this particular enzyme. You get intracellular lipid accumulation. Actually, the cardiologist probably may see this too. It affects children more than adults, but it's been described in adults in their late 60s. And so who you would think about this in would be somebody that presents with NASH but doesn't look like they should have NASH. So the last time I ordered this test was on a guy from Fort Knox that was really in good shape but had NASH. Turned out to be negative, but at least I thought about it. So there are commercially available labs that will run this test. So I've told you that this is a common disease, but it's poorly recognized. So this is a study that actually fellows did at a VA hospital, and I wish we had done it here. So they went back through CPRS, and they looked at veterans who had elevated liver enzymes. And then they put a filter on it. And so their filter were these things here. So persistently elevated liver enzymes, no viral liver disease, no alcohol, which took out a lot of the veterans, and metabolic syndrome and an elevated BMI. So they assumed that was NAFLD, and probably was. So then they took that group of patients and said, what did their doctors really understand about them? Well, only 39% did they recognize that they had an elevated ALT. And that's because the ALT is often just minimally elevated. So let's say 40 is your upper limits of normal, 44 is abnormal. And our normal levels are set too high. That's another problem. 21% had the possible diagnosis of NAFLD. 14% received a recommendation for lifestyle changes. So that's our number one therapy. Only 14% of patients got recommendations for lifestyle therapy. 10% were referred to specialists, and those that are high risk for fibrosis, only 3% were referred to specialists. So that meant it was unlikely that these people were getting HCC surveillance. So we don't do a good job of recognizing this. So in the histology of things, NASH is kind of the swing point. So a lot of people with just fat in their liver stay there. Once you progress to NASH, where you have inflammation and maybe a little fibrosis, you may stay there too. Or you can progress to cirrhosis, liver failure, and HCC. So the NASH, and here's the liver biopsy picture again. This is classic alcoholic hyaline that you see in alcoholic hepatitis. Here's cirrhosis, here's liver cancer. But the natural history is not really well defined. And part of it is we've really been studying this for a relatively short period of time. For sometimes a disease that might take 20 or 30 years to evolve. It's now a major cause of transplantation. It's relatively slowly progressive. So for each histology stage, it probably takes 5 to 7 years to progress from stage 1 to stage 2, or stage 2 to stage 3. And we're increasingly recognizing this in children, especially Hispanic children. So what's the differential diagnosis? How do we evaluate it? Well, very importantly, it's a disease of exclusion. So I have a bunch of people that were referred to me with presumed NASH. This is usually overweight women who have either PBC or autoimmune liver disease. So you have to exclude certain types of diseases, and sometimes you have to do it with a liver biopsy. So when should we suspect it? Well, again, we talked about history, that most of these people are asymptomatic. So they're not usually complaining about anything. If anything, it's fatigue and maybe a little right upper quadrant discomfort. If you have the presence of any of these things, especially with abnormal liver enzymes, you should think about NAFLD or NASH. And that includes the presence of obesity, especially morbid obesity, type 2 diabetes, metabolic syndrome, sleep apnea, insulin resistance, or again, chronically elevated AST and ALTs. So I share my clinic with Betty Villaferte, who's standing back there, and basically we see the same patients. So, diabetes, metabolic syndrome. She blames me for their problems, I blame her. So you want to talk to the patients very carefully about their alcohol intake. So again, this is the threshold that we use for a cutoff. Physical examination. So in my patient, the spiders helped out. So I was pretty sure this guy had more advanced liver disease. But central obesity correlates with inflammation on biopsy. Buffalo hump correlates with more injury. And again, we look for signs of advanced liver disease. What about laboratory tests? Well, this slide says about 10%, and that's probably a gross estimate of people have normal AST and ALT, so they can be picked up just by ultrasound. Or I have one particular surgeon that was actually with me when I was at the University of Kentucky, works in a little town in rural Kentucky now. And I have 1 or 2 patients a week that he does laparoscopic cholecystectomies and does liver biopsies on. And he sends them to me. And many of them have normal liver enzymes, but one of them a couple weeks ago had stage 3 fibrosis. The AST-ALT ratio is important. So again, the ALT is higher than the AST in NASH, and it's just the opposite in alcoholic liver disease. And again, the caveat is if NASH goes on to cirrhosis, then the AST and ALT may be the same, or the AST may be a little higher. Imaging, we usually use ultrasound because it's less invasive, less costly, and again, a lot of our patients are diabetics. We don't want to damage their kidneys. So what are the tests that we use to exclude other liver diseases? So we call this the Marsano panel. So we rule out hepatitis A, B, and C. Then we have to think about alcoholic liver disease. Especially in women, we're thinking about autoimmune liver disease, so we get ANA and AMAs. And then we think about hereditary and congenital things. So we sometimes have to test them for hereditary hemochromatosis, for Wilson's disease, alpha-1 antitrypsin disease. And obviously you want to think about drug-induced liver disease, so we can't forget about that. Now, we said that fibrosis is a critical factor, both for disease progression for the liver disease and for the other side effects, like cardiovascular disease, which I'll tell you about in a second. So how do we stage fibrosis? So on liver biopsy, 0 is no fibrosis. Then 1 and 2 are fairly similar. 3 is advanced bridging, and you can see almost a nodule there, and 4 is a nodule. So 4 is frank cirrhosis. Now, how do we assess fibrosis? So you can either do a liver biopsy, which most people aren't real enthusiastic about, or you can do non-invasive testing. The liver biopsy is great because it's our gold standard, but it samples only a very, very small fraction of the liver, so you have potential sampling error. On the non-invasive tests, the thing that we're very good at now is using FibroScan. But all these tests, the good thing is they're non-invasive, and we can use them serially, but some of them really aren't very highly specific or sensitive. And we'll talk about that. So we can use clinical parameters that should really make us think about NAFLD, and you can use little computer algorithms that if you put these things in will give you a likelihood of having more advanced fatty liver disease, and that would be like age, diabetes, and the metabolic syndrome. You can use elastography, and the thing that we most frequently use is the FibroScan. And then there are a bunch of serum tests. The serum tests are okay, kind of distinguishing nothing or stage 4. The stuff in between, not particularly good at, and there's a lot of things that can throw them off. This is a picture of FibroScanning here. Barbara Cave is standing back there, sitting back there. Hi, Barbara. So she does that up on the 3rd floor of the ACB in the hepatitis C clinic. So we've got a FibroScan there. We've got a FibroScan in Jewish. We've got a FibroScan at the VA. So we're incredibly fortunate. And so this is a quick, non-invasive way of looking at liver stiffness, which correlates with liver fibrosis. So you get a readout in what's called kilopascal units. And so if you're over here at 6 or under, you're basically almost sure to have nothing going on. And as you go up, you have increasing stiffness that correlates with increasing fibrosis. Now, there are some things that can give you a false reading, or there are situations when it's not even worth doing a FibroScan. So if you have acute hepatitis, all the time I have people that have alcoholic hepatitis that somebody wants to do a FibroScan on them to see how much fibrosis they have. It's going to give you a very falsely elevated reading, and that's because the inflammation in the liver causes that stiffness. Another big one, we see a lot of people with heart failure. That congestion will give you increased stiffness again, so a falsely elevated reading. Recent food ingestion, so these people are all supposed to be fasting. So in another world, in the hepatitis C world, and I probably shouldn't even talk about this, but back when it was very difficult to get drugs to treat hepatitis C patients with, they had to have stage 2 or greater fibrosis. And so if we wanted to kind of nudge that up a little bit, why, if patients ate a little bit, that could give you a little higher FibroScan score. So there are a bunch of things that can manipulate this. What about mechanisms of disease? So I've been looking at alcoholic liver disease for over 40 years. And the great thing is a lot of the mechanisms that apply to alcoholic liver disease also apply to NASH. And so basically we had a jump start on developing therapies. And this is a headache picture, but it shows many of the mechanisms and the types of therapies that we're using to try and attack those mechanisms. Put much more simply, it's a two-hit or multiple hit theory. So you have a baseline of fatty liver, and then you have something, so that's just that bland steatosis. And then you have something else that moves you into more severe disease. So fibrosis, inflammation, maybe even cirrhosis. And that includes oxidative stress, mitochondrial dysfunction, cytokines, insulin resistance, etc. And we'll go over these. So first, for oxidative stress, basically being obese is a state of oxidative stress. So this is a great article from the JCI where they looked at BMI in patients and looked at a marker of oxidative stress, urinary isoprostanes. And there was a correlation between BMI and urinary isoprostane levels. And various other assays have shown the same thing. And this oxidative stress can come from a variety of different sources. So cytochrome P450-2E1 tends to be induced both in NASH and in alcoholic liver disease. Peroxisomes, iron overload, the mitochondrial, which I'll show you next, and adipose tissue as a source of this oxidative stress. We mentioned mitochondrial dysfunction. So here's mitochondria in people that have fatty liver. So it looks pretty good. Here's NASH. They have these big mega mitochondria with these crystalline inclusions here. And so histologically, the mitochondria from simple fatty liver and NASH look different. My favorite topic is cytokines. So this is an article that we published back in over a decade ago. And we looked at cytokine levels, tumor necrosis factor levels in people with NASH, stable cirrhotics, and alcoholic hepatitis, and showed that the NASH patients were as bad as stable alcoholic cirrhotics. On the other hand, the good adipokine adiponectin is decreased. And again, this is a study we did here in Hispanic children, where we look at normal children, obese children without liver disease, and obese children with liver disease. And so low adiponectin is always a major problem. Insulin resistance is a huge driver of fatty liver disease. And so one of our big things is trying to get these people to lose weight and get their insulin resistance under control. A tough thing to do. Gut flora, which again is one of our favorite topics. NAFLD can be transmissible. So this is a study I love. It was a study in mice where they take a series of mice, they put them on a high-fat diet. And this is what we see all the time. If you have 10 mice, 8 mice do what you're supposed to. They gain more weight and get fatty liver. There's one mouse that gets humongous, and there's another mouse that nothing happens. And so they said, well, we're going to take the one that nothing happened to and the one that got humongous and do fecal transplants into germ-free mice. And so they did that. So the non-responder is the one that didn't gain weight on the high-fat diet. When they put his stool in the germ-free mouse, why, basically nothing happened if you look at his liver. So they put these mice on high-fat diets afterwards. On the other hand, the rapid responder got this terrible fatty liver. And so that showed you that you could transmit fatty liver basically by doing a stool transplant. Genetic modifiers are becoming increasingly recognized as very important, and especially modifiers of lipid metabolism. So Another board question for almost anybody anymore is polymorphisms in the PNPLA3 gene that Dr. Hobbs from Southwestern identified. So this is critically important in the development of NAFLD. It's also important in the development of cardiovascular disease. And it also helps explain the high prevalence in Hispanics. So they have a very high prevalence of a mutation of this particular gene. So overall, dietary stress is a big role. So if you look at Kentucky, why we're a fast food nation here. So we have Papa John's, KFC, and this is what I harp on my patients. Stay away from fast foods. That's a lifestyle modification you want to make. I've shown this slide a couple times before, I think, here, and shown it multiple times at other places. So how many people have seen Supersize Me? Okay. So Ryan Hurt, who is now at the Mayo Clinic, has given lectures here, took this movie, and when the doctor had the chart related to the patient, he froze the frames on this so he could actually pull off the laboratory values. And you can see that over the period of time that this guy was supersizing himself, his liver enzymes were going through the ceiling. I've actually never seen enzymes that high in fatty liver disease before, but I've never seen somebody kind of trying to eat themselves to death either. So this is actually why this guy had the whole thing stopped, because his liver enzymes were going so high. So what about complications? We'll talk about 4 different things here. I could actually spend 2 hours talking about complications, probably all day. But one of the most important things is cardiovascular events. So what do our patients with NAFLD die of? They do not die of liver disease. They die of cardiovascular events. And this is an incredibly important take-home point. And so all the things that lead to NAFLD also lead to heart disease. And if you look at intimal thickness, people with NAFLD are higher than controls, and there's a gradation. So steatosis is not as high as biopsy-documented NASH. And there's even a gradation in the different stages. So here's histologic stage 1, stage 2, stage 3. And so this is one of the reasons that staging is important, not only for your prognosis in liver disease, but also your prognosis in cardiovascular disease. It's a predictor of future cardiovascular events. And there have been multiple trials that have shown this. And so fat in your liver is basically your worst risk factor that you can have. Worse than cholesterol, worse than low, high sensitive CRP, you name it. Fat in the liver is your bad risk factor for cardiovascular disease. And again, a lot of the mechanisms, anywhere from insulin resistance all the way to fibrinogen and PI1, are common to cardiovascular disease and to fatty liver disease. So again, cardiovascular disease is the number 1 cause of death in people that have NAFLD. NAFLD is associated with increased prevalence and incidence of cardiovascular disease, and so we need to work with our cardiologists on this. It's both a target and a culprit in the pathogenesis of cardiovascular disease. These polymorphisms that I talked about are very important, and I think possibly the most important question in medicine today is, if we get fat out of the liver, can we fix cardiovascular disease? So that's a huge, huge issue that right now the FDA doesn't want to deal with. And I'll talk about that at the end if we have time. What about statins? So this has gotten better, but it used to be that Luis and I would spend half our time answering statin questions in people that had NAFLD. And so people with fatty liver disease regularly get put on statins. Then somebody checks their liver enzymes. They have an ALT of 45. And then they worry, is that due to the statins? What's going on? Do they have drug-induced liver disease? Am I going to get sued? What's happening? So this is the AASLD position statement. Every hepatologist in the world will tell you the same thing. Use statins. Don't worry about it. Don't call me. So, take-home point. Now, on the other hand, DILI can occur in people with NAFLD. One drug that we use a lot in GI diseases, and rheumatology uses it, the dermatologists do, is methotrexate. And so it's important to not put people with fatty liver on methotrexate because it's going to accelerate the disease. Severity of fibrosis predicts outcomes. So just focus here in this curve. So this is a large study, follow up over a large period of time. And we're looking at transplant-free survival, and you can see that the histology that you start with basically predicts your outcome. And so again, this is why stage of fibrosis is important. HCC is a critical factor, and we see more and more people with NASH who are coming in now with HCC. And I think in the future, this is going to be a dominant thing in our transplant service. So it's not quite the risk of hepatitis C, but very, very close, and a whole lot more patients. More often males, usually a single larger lesion. And so what you're supposed to do, and doesn't get done enough, is if you have cirrhosis, you should be getting an ultrasound and an AFP every 6 months. Now, the thing that nobody likes to talk about, we do screening for HCC in people that have cirrhosis. This is a VA study, but it just confirms what a couple other large studies have done. The best one was a national study in Korea. And what they're looking at is the people who develop HCC, how many of them, or what percentage, have cirrhosis? With HCV, almost all of them. Hepatitis B, all of them almost. Alcohol, almost all of them. NAFLD and idiopathic, and idiopathic is probably NAFLD in a large extent. Many more don't have full-blown cirrhosis. And so this is a concern. And it would be wonderful to have some simple blood test or some better screening procedure instead of having to do an ultrasound every 6 months, because right now our guidelines for HCC are for cirrhosis only, but we're going to end up missing some people that have stage 2 fibrosis with NAFLD. So prognosis and complications. End-stage NASH is often under-recognized, as it was in my patient. You need to think about HCC and screen for it. And these are the causes of why people die with liver disease, but importantly, the most important cause is a non-liver cause. So what about therapy? So We showed you this slide before, many mechanisms. So these mechanisms just give us many targets. And so there are a whole bunch of drugs that we're looking at now. But the most important thing is lifestyle modification. So if we can get somebody to lose weight and exercise, we don't have to worry about drugs. That works fantastically. And my favorite thing is coffee. I'm just starting the morning, but I have 20 cups a day. So I lecture to my patients. So we talked about portion size. So no going out to McDonald's and supersizing. Stay away from fast foods. My favorite thing is no sugared pop. So fructose kills. And then exercise. And you have to remember the patient population that you're dealing with. So a lot of these guys aren't going to go out and run marathons. So if you can do recumbent bikes, if you can do water aerobics or ellipticals, that's great. Again, fructose kills. So, and we've done a variety of animal studies here looking at mechanisms for this. There's a great paper out, fructose, it's alcohol without the buzz. And fructose is metabolized almost exactly the same way alcohol is. So here's our pyramid on how lifestyle modifications can actually histologically help your liver disease. So if you lose 3% of your excess weight, why? You can improve steatosis. 5%, you can improve inflammation. 7%, a lot of them will actually resolve their NASH. And you can actually even cause fibrosis regression. So lifestyle modifications are great. The problem is only a limited number of people will do it. Coffee, again, there is no upper limit. And there's study after study that show this. So it's important for fatty liver disease. It's even important in risk of development of HCC. And part of the mechanism is coffee may work like pentoxifylline, which I'll tell you about in a little bit. Bariatric surgery works. So if you have non-decompensated liver disease, these people do well. What about the things that we've used standardly, the things that are out there? Well, here's a long laundry list. The thing that we use by far the most is vitamin E. And so there are a series of vitamin E studies out, and this one in the New England Journal is the one that's quoted the most often and was a pivotal paper. So this is from the NIH-funded NASH CRN network. And so they treated adults with NASH, but very importantly, they didn't have diabetes. I think this was a bad part of the design because a whole lot of my patients have diabetes, and I disagree with the guidelines recommendations that we'll talk about. So they got randomized to placebo, Pioglitazone, or vitamin E and followed for a long period of time. And you can see, just looking at ALT, but they had repeat liver biopsies done too, that they got better on Pioglitazone and vitamin E, and then when they were stopped, their liver enzymes went back up again. So this showed the value of vitamin E, and the liver enzymes paralleled histology. So fat got better, inflammation got better. The problem was fibrosis did not get better. So remember, when you're using vitamin E, it's for inflammation and fat. If you have stage 3 fibrosis or cirrhosis, most of the fat's probably already gone out of your liver. So quit giving those people vitamin E. So I see a huge number of people coming in with cirrhosis with vitamin E. Probably not going to do any good. And they're already on 20 other medications. So this is a great review that was published in the Hepatology, where they took people who had liver histology and were followed up over time and looked at 4 major drugs, which are the ones that are mostly used. So pentoxifylline, vitamin E, thiazolidines, and obeticholic acid, which isn't released for NASH, but is available for PBC. So if we look at fibrosis, the thing that really works is pentoxifylline. So if I have somebody with fibrosis, I'm not putting them on vitamin E, I'm putting them on pentoxifylline. So that's important to remember. Obeticholic acid works too, but again, not approved for this and would be incredibly expensive. If we look at ballooning, why, basically almost everything works, but especially vitamin E, which again is dirt cheap. If we look at steatosis, basically everything works. So the bottom line is that if you have fat in the liver, you can use almost anything, but vitamin E is probably the best studied thing. If you have fibrosis, vitamin E is not going to help you, and those patients I give either pentoxifylline to, or if they can't tolerate that, I give them a probiotic. We have a bunch of new medicines that are out there. One of them's gotten pulled already. Actually, we were studying that here. The patients that I had on this drug were doing great. But there's a whole bunch of drugs in the pipeline. I'm not going to go over those with you because you can't treat your patients with them then. But what I would say is we have a drug for every stage of fatty liver disease in clinical trials. So if you have a patient that you're concerned about, you want to get them in clinical trials, give one of us a call. So what's our monitoring strategy? Well, again, we go with lifestyle modification, and we monitor that every 6 months. We follow their blood work, usually every 6 months or so. If they need to see us, and we would encourage that, especially if they have any advanced fibrosis, because we want to make sure we have them on the right medicines. Again, we usually follow these people every 6 months. The fiber scan, you shouldn't get any more than every 3 to 5 years. And again, that's because the natural course of the disease, one stage is usually 5 to 7 years. So I have a lot of patients that want to get tested every year. And I said, it's just not going to help. The variability of the test and how much your fibrosis is changing, you're not going to get good information. So in conclusion, this is the number one cause of liver disease. Every one of you are going to see this in your practice. We now use FibroScan for fibrosis, so this is a great test, and I think we're going to have even better tests in the future, but we've got this now at U of L Hospital, so go see Barbara. We've got it at the VA hospital. We use it regularly. Treatment options, you need to treat patients with the right drug for the right phase of their disease. So everybody gets lifestyle modification. The AASLD recommendations are vitamin E for non-diabetic NASH. I give it to diabetics, and I don't see why they shouldn't get it. So I don't necessarily agree with that recommendation. So we give it to everybody, whether they're diabetic or not. And part of this is a huge number of our patients, again, have diabetes. You can give Pioglitazone if they're already on it for their diabetes. The glitazones I have issues with because they cause weight gain. And again, as soon as you go off that drug, just like vitamin E, the fatty liver comes back. So I have people gaining weight over a period of time that I don't like. I use pentoxyphylline extensively for people with fibrosis. The main side effect of that is nausea, and it's a 3-time-a-day drug. So if they can't tolerate that or won't take it, I give them a probiotic. We clearly consider bariatric surgery for morbidly obese patients. HCC monitoring is critical, and it's a good way of getting sued. It's just a vital thing to do for our patients. And again, we finally have a bunch of new drugs in the pipeline. So if you have patients that are advancing in their disease, you want them on antifibrotic medications, send them to us. Thank you.
One question. One other presentation, of course, is low testosterone.
Right.
And many of the men who present with low testosterone really have a low level of SATD, transport protein, which carries testosterone around the blood, which is intimately related to the amount of fat in the liver. So it's a clue. Rather than treating your patient with testosterone, think that when he's presenting, he has what they call adult onset hypogonadism, and it doesn't have food or anything wrong with his testes. Think that maybe that low total testosterone is really an indicator that he has NAFLD.
Right.
So my question then is back to your comments on the racial difference. So African Americans have a very low prevalence of NAFLD.
Absolutely.
Guess why that is.
So again, the PNPLA3 genetic polymorphism parallels the racial differences. So that's one thing. So I think it's probably genetics, but you're absolutely right. So I have 2 African Americans that I can think of in my practice with fatty liver disease. So it's incredibly unusual for me to see an African American with especially advanced fatty liver disease. On the other hand, when we were doing studies in Hispanic children, we almost could not find an Hispanic child that didn't have fatty liver disease. It was amazing. So the ethnic differences are huge, and I think part of it relates to genetics, and I think part of it relates to diet. And as you know, obviously African Americans are overweight, can be overweight, and they have strokes and heart attacks, but they don't get liver disease for some reason.
Really nice presentation. In the studies looking at coffee on fatty liver disease, did they look at both caffeinated and decaffeinated? Is there any thought to what particular component in coffee was different?
Right. So it's most of the studies have looked at caffeinated, and the mechanisms haven't been totally worked out, but coffee is like pentoxyphylline as far as being a phosphodiesterase inhibitor. And so there are incredibly potent specific phosphodiesterase inhibitors that we're very enthusiastic about for treatment of NAFLD. There's actually one of them that's commercially available for psoriasis right now, another one for pulmonary fibrosis. But it's mainly caffeinated coffee, but interestingly, nobody's shown a protective effect with tea, for example, which has caffeine in it. Yeah.
I just wanted to comment that whenever I read in the popular press about health problems around overweight and obesity, I have never yet once seen liver disease mentioned in the ever-expanding list of health problems caused by obesity. So I'm just commenting that these are cut out of experts.
Yeah, I mean, yeah, it's a huge, huge issue. And, we try and publicize it as much as we can. But, and again, we think the liver disease and the cardiovascular disease are incredibly closely linked. The battles that we've had I've had specifically with the FDA, they want to focus on more end-stage liver disease for new drugs. I think if you were able to show that if you got fat out of the liver and it reduced your cardiovascular risk, that would be the most important drug developed. That could be vitamin E. If it were vitamin E, a lot of drug companies wouldn't be happy with that. So, but you're absolutely right. It's poorly advertised. It's getting better advertised in children, but still in adults, you don't hear about it. One last question.
Okay, so regarding diet, you mentioned fast food and this, but some people are getting low carb, for instance, to lose weight more effective than trying to eliminate the fat.
Yeah, so really it doesn't make any difference what your mechanism of losing weight is. Ultimately the weight loss. So however you do it is effective. The simplest thing for us is getting rid of fructose first if you're a pop drinker. And we know that fructose is especially bad. The fat story is highly complicated because saturated fat may not be nearly as bad as some people think. And the unsaturated fat is complex because we think N6 fats are especially bad, omega-3s are good, and we get a lot of people confused on fat stores. Okay, thank you very much.